Hi guys, Dr. Douglas Chillard here again. It is Thursday. It is week 6. It is the big GIGU lecture. We're going to finish stomach conditions and then we're going to get into some intestinal pathology, specifically small bowel obstruction and its sequelae today. So here we go. Now, where have we been? It's been a week or so since we've done this. So we are talking about the gastritises last time, if you'll remember, and we said that system was a terrible mess the way they've classified all the disease. The Sydney classifications have made a valiant attempt to fix this problem by making really 3 groups of stomach conditions: non-atrophic stomach conditions, or gastritises as they call them. I prefer gastropathies, but non-atrophic gastritis, atrophic gastritis, and then the special cases of gastritis. And let's see, we got through the non-atrophic gastritis. That's an H. pylori infection that hits the pyloric region of the stomach. And that's the most common of all types of gastritis. And who cares about gastritis? What does it do? Well, it causes the patient to have stomach pain or dyspepsia, and we talked all about that. There's a whole bunch of AKAs for non-atrophic gastritis, but yep, that's the story. Then we got into the atrophic gastritis family. There's 2 subcategories of atrophic gastritis. There's autoimmune and there's multifocal. And we finished, I think we almost finished autoimmune atrophic gastritis, but that was caused by an autoimmune attack against the stomach itself, specifically against fundic glands or oxentic glands in the fundic region of the stomach. Right, and we've actually studied that before because that is a cause of one of the causes of vitamin B12 deficiency or pernicious anemia, because intrinsic factor is not made in that case. Right, and we're going to get into multifocal here in a minute. All right, and yeah, just everything I just said about autoimmune atrophic gastritis. To recap, it's an attack on parietal cells. So type 3 autoantibodies will be present. It inflames the fundic glands, which basically inflames the fundic region of the stomach. And therefore, if the fundic glands are broken, there goes your hipster, right? No hydrochloric acid, no intrinsic factor, no pepsinogen from collateral damage. Remember, the chief cells are right next to the parietal cells. Okay. So hypochlorhydria, which is decreased hydrochloric acid, or even achlorhydria, will be present, but hypergastronemia will be present because there's nothing to turn off the G cells, and they're not involved in the autoimmune attack, so they work fine and they secrete very high levels of gastrin. All right, so what are the histological signs? I guess we're still finishing up autoimmune gastritis. What are the signs of a autoimmune attack? Well, the ECL cells and the G cells will be overworked. Remember, there's nothing to turn off the G cells from doing their job. They're turned off by high levels of acid in the stomach, and we don't have high levels of acid, so they'll be turned off. Or they'll be turned on all the time, so just like lifting weights all the time, they start to get big and hypertrophic. And the gastrin they create binds to ECL cells, and they're working all the time. So they'll be hypertrophic as well, so you can, a histologist or a pathologist can specifically see those findings. And therefore, it's said that you get hyperplasia of both G cells and ECL cells with this condition. How about some associations with autoimmune atrophic gastritis? Well, it is an autoimmune disease, so you may have other autoimmune diseases, such as iron deficiency anemia, psoriasis. These are all autoimmune driven. Iron deficiency anemia is not in and of itself, but that's something seen in pernicious anemia. So pernicious anemia is always seen in this condition, and then one of the associations with pernicious anemia was iron deficiency anemia, but all the rest of these are autoimmune driven. Psoriasis, psoriatic arthritis, Hashimoto's disease, which is hypothyroidism. In fact, 33% of people have this one. Type 1 diabetes, autoimmune. Sjogren's disease, autoimmune. Rosacea is believed to be autoimmune as well. What about the risk of cancer? It's not as high as the next category we're going to look at, but there is a slight increase in the risk of developing stomach cancer, which we said is a horrible cancer to develop. There's about a 3-fold risk for this condition. And that's secondary to the chronic irritation and inflammation of the fundic region of the stomach by the autoimmune. Anytime you have chronic inflammation, that increases the chance of you starting to get some mutated cells, and they become immortal cancer cells and they divide too fast. That's cancer. How do you treat atrophic autoimmune gastritis? Vitamin B12 injections, because you're going to have eventually pernicious anemia. You might want to take immunosuppressants to slow down the destruction of the stomach. You might need, for the dyspepsia, you may need some kind of pain medication. Tylenol, acetaminophen is a pretty good one for that. Of course, check with your primary health care provider before that. You might need something stronger like hydrocodone if it gets really, really bad. And yep, you have to watch for iron deficiency anemia to pop up. If that does, the treatment is ferrous iron salts you can take for that one. Some fun facts. It's interesting that people with autoimmune atrophic gastritis are protected from peptic ulcer disease and from GERD. Why would that be? Well, autoimmune atrophic gastritis is a destruction of the cells that make acid, so you're not going to have acid. If you don't have acid, you're not going to get ulcers, or you're not going to have GERD, or you're not going to have a Barrett's esophagus or esophageal carcinoma, which is all stimulated by overproduction of acid. What about endoscopic assessment if you go down there and look around? Well, we said that there might be visible, if it's been going on a long time, there might be visible destruction of the stomach. The body and the fundic region of the stomach usually have rugae, and those can be blown out because of this disease, because of the chronic inflammation. In fact, here's a normal fundic and pyloric region. We've seen this in anatomy, right? All this, not this real of a shot, but we've seen our kind of dried out cadavers. But here's someone with chronic autoimmune atrophic gastritis. The rugae are gone. Right? How come? Because the chronic inflammation has just destroyed all that tissue. ECL cells have gotten hyperplastic and kind of flattened everything out, and G cells too. All right, that's enough about that. Let's move on to multifocal atrophic gastritis and get into that one. Another AKA mess, maybe not quite as bad as some of the other categories, but environmental metaplastic atrophic gastritis. Environmental is sometimes a word used by older texts like Robbins, but we know more about it now. But environmental is possibly some environmental factor. It might be driving this disease that we don't know, something floating around in the air. It's not type A, it's not type B, but it's type AB chronic gastritis is another AKA that's fairly commonly used. Metaplastic gastritis, because this one causes cancer. HP-associated atrophic gastritis is another one, but this is a terrible one, really, because we know HP also causes atrophic gastritis. So that's not, or non-atrophic gastritis. HP also causes non-atrophic gastritis, so that's a terrible AKA. I hope they don't use that on boards. Got to use one of these other ones. Just multifocal atrophic gastritis is the one that should be used. The key words when looking at any type of board are look for pan, because it's the entire stomach is affected. Right, that's the atrophic pan gastritis. Remember, non-atrophic gastritis affects the antrum, and autoimmune atrophic gastritis affects the fundus in the body of the stomach, or the fundic region of the stomach. This one infects the entire stomach typically. So therefore, sometimes it's called a pan, meaning everything gastritis. So environmental, look for AB, HP, atrophic. Those are some keys. So let's talk about it. It's the second type of atrophic gastritis. Autoimmune was the first, thought to be caused by two main things. HP infection, and not the initial HP infection which affected the pyloric region. This is an HP infection that has taken over the entire stomach, which is a little unusual. And then the other 25% of the cases, 75%, is thought to be from a chronic HP infection. According to Greenson, which is a very evidence-based, much, in my opinion, much better than Rubins and Robbins. For this, Rubins and Robbins tries to, in all fairness, it tries to cover all pathology. This is just focused on gastrointestinal pathology. But 75% of the cases tend to be chronic HP infections. The other 25, they can't figure out what is causing them. There's a chronic inflammation, but they don't know what the cause is. It's thought to be some environmental factor, but I won't go into all the theories on that. So again, MAG destroys, multifocal atrophic gastritis, destroys the entire stomach. It's also considered a pan-gastritis because it affects the entire stomach. That's why that word comes from. It greatly increases the risk of stomach cancer. This is the take-home message. Multifocal atrophic gastritis, it's stomach cancer. You have to be really careful with this one. And again, Rubin's, which is one of the chiropractic board books, says the etiology is unknown, but says it's a precursor to cancer. But we know that for the last 10 years we've known that HP is a major cause of this. So Rubin's needs to get updated. Many cases it's believed to result from a progressive or a progression of non-atrophic gastritis, right? So the very first stomach pathology we talked about was non-atrophic gastritis, which is caused by an HP infection of the antrum of the stomach. And if that goes on and on and on, pretty soon the bug will spread and take over the entire stomach, and now you have an atrophic gastritis. See how that works. But again, that's not some people with MAG, multifocal atrophic gastritis. They do biopsies and they look in there and there's no HP. It's some just chronic inflammation. It's not autoimmune, and they don't know what it is. You can, if it's a chronic HP infection, we've talked about that. You can do a blood test to detect antibodies. There'll be an IgG antibody present, specifically the IgG anti-H. pylori antibody will be present in most people. That won't tell you if this is a new infection or an old infection, though, because once you've had HP, this antibody will always be patrolling the blood, so it'll always be present. So you might not have, in other words, you might have this antibody present and not have a current infection. It could mean that you had H. pylori in the past, maybe it was treated, but you don't know if there's an active infection. All you know is that you once had H. pylori, if that makes sense. The only way to tell if you have H. pylori is to do a stomach biopsy. That's not the only way, but that's by far the most accurate way. There is a test called the carbon isotope urea breath test. I've had this before because I've had HP in the past and had stomach upset and my antibodies were present. But that doesn't mean that I didn't have an HP infection. So you breathe into this tube. It's about an hour test. You do a lot of exhaling into a tube after drinking the solution, which temporarily kills the HP and releases ammonia, and they detect the ammonia that's coming out of your breath. And if you have a lot of ammonia coming out of your breath after the bug has been killed and releases that ammonia cloud, it's pretty strong evidence that you do have an active HP infection. All right. Yeah, now this is interesting too. Sometimes, and here's a histological sample. You can see all the black little dots here. Those are bugs. Those are HP. So sometimes the infection gets so robust that it destroys so much so much stomach tissue that there's no place for it to live anymore. It has to have glands to live in, and it can kill all the glands, and your stomach stops secreting everything, and there's no more tissue for it to live on, so it can kind of kill itself off. Right, and yeah, it isn't always HP, as we said, right? But 25% of the time you go in there and you test and there's no HP. You don't know, you see the inflammation, you see the destruction, the loss of rugae, and you go in there and there's nothing there. So what's stimulating the inflammation? We don't know what that is. There are some theories that I'm not going to get into, but certain environmental toxins are causing, almost like Berger's disease where cigarette smoke does it. But yeah, it's kind of a mystery. All right, that's all we'll say about that one. Now let's get into the special types or special forms of gastritis. So here they are. Here's the players. There's the chemical gastritis, the radiation, lymphocytic, non-infectious granulomatous gastritis, eosinophilic gastritis. I used to cover all these. It's just too much information. We're just going to cover the most common, which is chemical gastritis. Right? A lot of the experts are really pushing, maybe for the next Sydney meeting, they're going to try to change this one again into gastropathy, the word gastropathy. Because these chemical, and what are the chemical causes of stomach irritation? Alcohol, bile is really common, NSAIDs. These are very common problems. It's where the stomach is flat out damaged by the stuff you're taking. I mean, if you accidentally drink antifreeze, that doesn't happen that often, but yeah. And there's no inflammation. The inflammation doesn't damage. It doesn't start out. The stomach is flat out damaged by the chemicals. Like drinking shots of moonshine, for example, will quickly damage the stomach. It goes right through the gastric mucosal barrier, right through the mucosal layer, into the lamina propria, and stimulates nerves and destroys tissue, and it can go in the submucosa and do the same thing. And it doesn't need an inflammation to cause the problem. That's why they really want to get away from the word chronic gastritis, which of course Robbins still uses. So a reactive gastropathy is the best term for this, and that's perhaps what they're pushing for. All right, so chemical gastritis, nevertheless, that's how Sydney is classifying it, and that's what we're going with. A lot of AKAs, shame. I basically just said all this, went through this stuff again. Yeah, again, many of these are really, when you say itis, it's a bad term because there's no inflammation initially that causes the damage. There might be inflammation that occurs after to clean up the damaged tissue, but that wasn't the cause. Inflammation was not the cause. So it's better to call this a reactive gastropathy, like Sleisenger uses, reactive gastropathy. Okay, still, let's see. So what are the causes of this? Again, we said alcohol, NSAID, bile. We'll talk about this a little bit more, the bile reflux, here in a second. And then accidental poisonings by antifreeze and such. Is a condition characterized by a sudden onset of pain? And this is something that doesn't slowly build up. You do shots of moonshine and you wake up in the morning and you're severe pain. So it's severe dyspepsia could be one of these things. It can progress because you've damaged the stomach or intestinal lining, so you can bleed. So you can have bleeding from this condition as well. Again, the initial injury and pain is not caused by inflammation. It's caused by a failure of the gastric mucosal barrier to protect the stomach like it's supposed to. Remember, we've talked in great deal about this gastric mucosal barrier, how important it is, and the mucosal cells create this, and PGE2 is responsible for this as well. And COX-1 enzyme is needed to make this thing go. But if this fails, and sometimes it's not, there's nothing wrong with the GMB, the gastric mucosal barrier. Sometimes it's just overpowered by moonshine or chronic use of aspirin. Aspirin is acidic. You can burn a hole right in your stomach from the aspirin. That's why you always take aspirin with food. But sometimes it is a problem. Something knocks out the GMB and you can get destruction. The natural acid can be the chemical gastritis irritant if the GMB fails. Right? Yeah, so typically that something doesn't cause inflammation. It physically damaged the tissue. To that point, when pathologists look at a sample of tissue in somebody with a chemical gastritis, they won't find any neutrophils, which are classic of inflammation, or very few of them. So they'll come in later to clean up the dead tissue, but it's not the cause. So that's why it's better to cause it gastropathy again. Chemical gastritis, I do like that. I mean, reactive gastropathy, I do like that, aka. What does the endoscope look like? Well, you can see destroyed tissue right off the bat. So you see these red streaks on the mucosal surface. There'll be some hemorrhage. There may be ulcers present. There may not be. There may be a lot of blood present. So this is a flat-out injury. So here is a stomach. The pyloric region here is damaged. You can see all the raw stomach tissue. And yeah, this one was secondary to bile reflux. So the bile was getting backed up and refluxing because the pyloric sphincter wasn't working. We haven't talked about that, but just like the lower esophageal sphincter being messed up, the pyloric sphincter can be messed up and loose and let bile regurgitate. And your stomach hates bile, absolutely hates it. And it's caustic. It'll rip up your stomach like this. Right? Aspirin, we said this already. NSAIDs, high-proof alcohol. Used to talk more about that, but I took most of those slides out. But ethanol, probably one of the most common causes, especially strong alcohol. And a few shots of any type of alcohol can cause, they've done experiments in college students where they've had them take shots and then they stuck a scope down there and took a look. And very quickly the stomach gets red and there can even be micro bleeding following a bunch of shots. That's why you don't feel good. Your stomach can be upset for a couple days while the lining turns over. Oops, sorry, I forgot to. Disturbing picture coming up. Sorry about that. But, so what do we have here? This is horrible, right? This is a severely burned patient. I don't know what the percentage is, but it's probably over 50% of her body. And she's probably not going to make it. Now, what's the problem here? So how can she get an upset stomach, a severely upset stomach, and actually bleed, and that could actually be the cause of death? They'll give her PPIs. Why in the world? And she's not even eating. She's too sick to eat. How can she have stomach problems if you're burned? Well, what happens in a burn? What happens to all the albumin? Right? All these capillaries are destroyed, and she's going to be, this is really acute, this is a fresh picture, but she's going to get more puffy and puffy and puffy. Feet are getting a little puffy looking, fingers look a little puffy. But she's leaking albumin. And we said we need albumin to pull interstitial fluid back into the distal capillary. And so she's going to have widespread over interstitium. The interstitium is going to be too filled up with fluid. Well, what's that got to do? Well, what's going to happen to the gastric mucosal barrier? It has an interstitium underneath the all the cells, all the mucous cells have an interstitium, and it's going to be overloaded with fluid. Well, how is glucose and oxygen going to get through all that fluid to feed the cells? That's the problem. If you have swelling in your stomach, which you can't see, but it's there just like on the outside of your body. If the stomach lining is swollen, it's really hard to get nutrients to swim through all that interstitium and find the cells to service them. So they start dying. And if your mucous cells of your stomach start dying, what's going to make your gastric mucosal barrier? Nothing. So you're going to have a slow, probably sympathetically derived release of acid in your stomach with no gastric mucosal barrier to protect it. You're going to burn a hole right in that stomach really quick. And I just went through all the slides. But yeah, how could a burn victim suffer a reactive gastropathy? Well, albumin is lost, as we said. And yeah, without albumin, you can't, the interstitium is flooded with interstitial fluid. And you swell, and your stomach lining swells. Right? So the interstitium becomes very congested, and the nutrients can't swim through it. And the mucous cells become ischemic and die, and there goes your gastric mucosal barrier. And we know how those mucose cells are so important, right? They secrete mucus. They turn off acid via PGNE2. Well, PGNE2 stimulates them. Remember we talked about all this, how PGNE2 autocrine and exocrine has an autocrine and exocrine function. It stimulates itself to produce mucus and bicarbonate, and it goes over and binds to ECL cells and shuts them down. So it slows the production of acid. So all that is gone, you're going to be in trouble. And yeah, so this is just, here's a mucose cell, and here's glucose that has just come out of the proximal capillary, and there's oxygen. And it can't, usually it doesn't have any trouble swimming to feed the cell, but there's so many other molecules of water around it, it's colliding with them, and it's having trouble servicing these cells, especially ones that are a little bit farther away from the capillary, and these cells start dying, they get distressed, and they stop making the gastric mucosal barrier. All right, and then there's nothing to stop the acid from ripping a hole in the stomach. Yep. The ulcers that occur in burn victims have a specific name. High yield question right here. Make a note card of this. Curling ulcers. Curling ulcers. And those occur from that same mechanism I just said right there, because of all the swelling. Because of what causes curling ulcers? Its albumin is lost from the bloodstream, and you lose your oncotic sucking force. That's such an important concept. Right? There's a curling ulcer in that patient that we just saw. All right. NSAIDs, we've talked about this, so I'm not going to go quickly over this, but we already said that NSAIDs knock out COX-1, and COX-1 is in mucose cells. We need COX-1 to create PGE2, and PGE2, of course, is the one that makes the gastric mucosa barrier. So if you knock out PGE2, there goes your gastric mucosa barrier, and you can get ulcers and perforations and peritonitis. I think we know that mechanism pretty good. How about some other things that could cause a reactive gastropathy or special forms of gastritis, if you have to call it that? Mercury, selenium, ketamine, recreational drug, inhaled ketamine, special K, right? So really, really tough on the mucose cells. We'll get into the mechanism there. Interesting, Stanford in a paper in February 2019, they're actually using ketamine for treating severe medication-resistant depression. Seems to be working really well. So there's actually use for special K that's not for recreational purposes. Bile reflux. The stomach hates bile. That's why the committee made the pyloric sphincter so darn strong. Bile has to be kept in the duodenum, cannot come back up into the esophagus. There's some AKAs for bile reflux: duodenal pancreatic reflux, alkaline gastritis, because there's also bicarbonate that comes up with the bile. Bile reflux gastritis. I'm just going to call it bile reflux or bile reflux gastropathy. And it occurs when the pyloric sphincter fails for whatever reason and bile backwashes into the stomach. Bile is very caustic to the stomach. It goes right through the gastric mucosal barrier and wipes out the stomach. Very difficult histologically speaking to differentiate these, alcohol versus NSAIDs versus bile. All of them, the one common thing is there's destruction, there's ulceration and death of tissue, but there's not a lot of inflammation around until the chronic phases of it, until the cleanup needs. So again, that's why it's not good to call this a gastritis, which indicates inflammation and has nothing to do with inflammation. You'd think the authors would get on the ball and fix that. Maybe the next Sydney classification they will. All right. So what are some other risk factors for bile reflux? Stomach surgery, especially a tummy tuck, gastrectomy. About 20% of them, they develop bile reflux because of this. chronic coughing diseases, COPD, obesity, anything that increases the pressure in your stomach, like if you have a lot of extra fat in your stomach, that fat pushes into your intestines and increases the pressure, and it squeezes, it's putting a pressure encouraging bile to reflux into the stomach, as well as causing acid in the stomach to reflux into the esophagus. So obesity. Heavy lifting occupations where you're lifting heavy all day. What are the symptoms? Well, upset stomach or dyspnea is the classic symptom. If the duodenum gets involved, you can start to get some blood, whether it be red or coffee grounds, depending how long it sits in your stomach, but you can start vomiting blood, hematemesis. If some of the blood goes through the intestine, gets processed, it can look tarry when it comes out in the stool, giving you a tarry stool. That's melena. We've talked about that before. One thing about bile reflux, it'll kill off HP. Even HP can't stand the bile, so that's not a recommended treatment for HP, though, of course. How do you treat reactive gastropathy? Well, you have to find the cause. If they're an alcoholic, they need to get into rehabilitation and stop that. If they have chronic pain and they're taking aspirin, you have to try something else. Maybe they need a spinal cord stimulator. If acid is being driven and overproduced, PPIs, H2 blockers, antacids should be used, because the acid is the one that's causing all the trouble, right? The GMB is gone. If the GMB is gone, you better shut off the acid as much as possible. And then modified diet, all the things we talked about for GERD and for dyspepsia, that bland diet, no red sauce, no alcohol, small meals. If none of that works, then the ultimate fix is to go in there surgically and tighten up the pyloric sphincter, which can lead to other troubles like delayed gastric emptying, but we won't go down that rabbit hole. All right, so that was the first lecture. We'll keep right on going, though, today. I'm going to combine these things. So now let's get into the intestinal conditions. So the big one here is small bowel obstruction. So a little review of the stomach and the intestines, right? So we have the stomach we've talked about. We've talked about the esophagus a lot. The intestines have three parts. This first little C-shaped curve here is called the duodenum or the duodenum or the duodenum, tomatoes. And then it meets the jejunum right here. Remember the ligament of Treitz is holding this, supporting this up here. Anything this way is called is upper, and anything down here is lower GI bleed. So an upper GI bleed would be anything here to the stomach, to the esophagus. Anything downstream to the duodenum is a lower GI bleed. Okay, so this green, what is this, aqua color? That's the jejunum. And of course we're moving toward here. Our goal is to get, if you have food material and you want to make a fecal material out of it, it gets processed as it goes further and further through these tubes. Water gets sucked out of it, nutrients get sucked out of it, and it gets more dehydrated and becomes fecal material. Right here is always a dangerous spot, right at the ileocecal valve. The green here, of course, is the ileum. We've talked a lot about this distal ileum right here. That's where the cubolin receptors are. That's where B12 is taken up only in this region. And then there is ileocecal valve, and then the fecal material drops into here, and now we're in the large intestine. This is actually called the cecum of the large intestine. There's the appendix. Ascending intestine. Hepatic flexure is the elbow, the curve here. Transverse colon, ascending colon, transverse colon, descending colon. And instead of a cecum over here, we have a kind of a S-shaped region called the sigmoid colon, and that goes into the rectum and then the anus. Okay, and let's remember too that the intestine is a tube. It's got a lot of muscle in the wall, so peristalsis will squeeze this part and propel the fecal material that way. This rhythmic contraction of this smooth muscle is key. Peristalsis is key. Can't live without peristalsis. Won't get into all the layers, but they're the same layers we've talked about. Serosa layer, And then we have a double muscular layer, not a triple, double. Stomach has a triple. Just like the esophagus, this is a double with longitudinal muscle on the outside. And circular for center, C for circular means C for center, circular muscle here. We have our box plexus, you can see. If we go down to the submucosal layer, we have Meissner's plexus. Some authors even split Meissner's plexus into two plexus layers, an internal Meissner's plexus and an external Meissner's plexus. And then this is this of course is the mucosal layer made of columnar cells. These are not mucose cells, they don't secrete mucus like the simple columnar cells of the stomach do. They sit, there's a basal lamina they sit on, and then there's a little muscular layer, muscularis mucosae, which helps a little bit with peristalsis. Alright, so an intestinal obstruction is basically a blockage of the pipe. Let's say you have a tumor growing like this inside. Right? How's fecal material going to get through there? Maybe a little bit can get through up here. But see what I mean? That's a beaver dam. Right? So fecal material is going to back up, upstream, and bacteria are going to, this is filled, of course fecal material is dirty, right? It's filled with bacteria. Can't stay in your intestine too long, especially up high like this. And the bacteria can breed, and they can, take over. Right? So it occurs when something blocks the downstream flow of fecal material. That's called the arboreal flow. Arboreal means the downstream flow. Something blocks it, so you get some type of beaver dam because of that. And eventually it's going to cause severe pain as the bacteria get stuck there. They multiply, they release methane gas, and the gas expands the intestine. And more of the fecal material starts piling up if you're still eating, and the gas and the fecal material pileup stretches the intestine, and the intestine has little pain sensors in there that will respond to stretch and cause horrible pain. And it is one of the common causes for acute abdomen. Remember, that's the 10-10 horrible pain. You'll go to the hospital no matter if you have insurance or not. You will go to the hospital because you think you're dying, and you might be dying. And let's fall down a rabbit hole. Let's talk about acute abdomen. I thought I talked about it, but I guess I didn't. Acute abdomen is a 10-10 horrible, I'm going to the hospital type of pain. It's associated usually with vomiting and nausea, and it can go into dehydration, which can lead to hypovolemia, and you could go into hypovolemic shock, and it's a life-threatening situation. It can also cause peritonitis, and you can get septicemia on top of that. It's a very, very serious condition. Here are the causes. This is always good for a question here. What could cause acute abdomen? 2 questions, maybe 3 questions. You need to study that. You need to know if somebody has horrible stomach pain, what could it be? Could be acute appendicitis. We'll teach you in lab how to find appendicitis. It could be from a peptic ulcer, meaning an ulcer in the stomach, or duodenum that has perforated or is near ripping right through the entire full thickness of the intestinal wall. Acute pancreatitis, diverticulum that gets inflamed, diverticulitis. An ovary that twists and gets snagged, and the blood gets cut off, and the ovary starts becoming ischemic. Ectopic pregnancy that occurs especially in the fallopian tube and rips the fallopian tube, incredibly painful. Intestinal obstruction, which is kind of the star of the show now. A volvulus or intussusception, we'll look at these. Twisting of the bowel. And intussusception is one bowel slides into the other part of the bowel. We'll look at that in a second. Ruptured aortic aneurysm. Injury, a lacerated liver or spleen from a car accident. Lots of pain fiber in there and around that area. Cholecystitis, so inflammation of the gallbladder from gallstones. Urolithiasis, those are kidney stones. Bowel ischemia from vascular obstruction. Okay, there's 2 main causes of obstruction. So you can have a complete blockage of the pipe, Oh wait, we haven't got to that yet. There's two main causes of obstruction. So you can have a mechanical blocking of the pipe, like a tumor, like we drew. There's something physically blocking the flow of fecal material through the pipe. Or remember we said peristalsis is really, really important for making this work, to push fecal material through the pipe. What if that breaks down? What if the enteric nervous system stops working? That's called a functional or a non-mechanic. This is an easy slide for a question, isn't it? So mechanical is by far the most common. So let's look at mechanical obstruction right now. So it occurs when you get some kind of beaver dam in the lumen of the intestine gets pinched or blocked by something. It beaver dams. And in this case, here's a beaver dam right here in the jejunum. And you can see what happens upstream. The bacteria the fecal material have backed up, and it's blown the tiny small intestine to probably 5-10 times bigger than normal. And this can rupture, but the stretch receptors are all stimulated, and this patient has horrible pain. And then downstream from the beaver dam, you got nothing. There's no poop going through. There's no water being reabsorbed. You're going to become dehydrated. And yeah, it's a 10. It's a cause of acute abdomen. So what are the causes of this mechanical obstruction? By far the most common type is intestinal adhesion, which of course we'll talk about later. But in adults anyway, that's the most common type. Hernias, where you have a defect in the abdominal wall in the intestine, goes through that hole and gets pinched by the hernia. That is about 10%. And we'll get to hernias. Intestinal carcinoma, that was like the picture I drew, where you get something growing in the lumen. Other causes as well. Intussusception. So this is actually the most common cause of obstruction in children. Right? It occurs when the upstream piece of intestine pushes into the downstream piece of intestine. Okay? And volvulus is where they twist on one another, but let's look at these two here. Or let's look at intussusception. So this usually occurs, it can occur anywhere, but it likes to occur right at the ileocecal valve. So for whatever reason, something gets a little stuck here, peristalsis ramps up, and it actually pushes the intestine, this last part of the ileum, gets pushed into the large intestine, just like this picture. So you have intestine, small intestine within large intestine. And that's an intussusception. The point at which the kind of ferreting occurs, like ferrets are little ground squirrel-like animals. They like to dig tunnels. So this can be called ferreting, or the intussusception occurs. That's called the lead point. So in this case, the ileocecal valve is the lead point. All right, so that is, a Meckel's diverticulum, which I used to teach and I took out because of time, is a common risk factor for this thing as well. A volvulus occurs when a piece of scar tissue called an adhesion develops, and it kind of tangles up the intestine. And peristalsis gets the intestine just kind of twisted on itself. And if the intestine twists, here's a fecal material that's got to get through this. How are you going to get fecal material through there? Well, you're not. It's going to get stuck right about here and cause a beaver dam. See how that works? Some other more rare causes, a stricture is a tissue buildup, not from the outside. This adhesion is a condition that occurs outside the intestine and entangles it. A stricture is the same thing. It's scar tissue, but that occurs inside the lumen of the intestine. Okay, and what causes that scar tissue is chronic bouts of inflammation of the intestinal wall from conditions like Crohn's disease or radiation therapy. Crohn's disease in particular. What else? Something called gallstone ileus is interesting. So this is a complication of gallstones where the gallbladder gets inflamed and it sticks to the intestine, and the inflammation is so great that it causes a hole between the gallbladder and the intestine, and they stick together. That's a fistula, right? And then all those gallstones jump into the intestine, and they roll through the intestine and they get stuck right at that ileocecal valve, and now you got yourself an obstruction because you can't get fecal material through the ileocecal valve because there's a whole pile of gallstones there. So that's called gallstone ileus. Right? Here's a patient with gallstone ileus. You can actually see the liver, the outline of the liver. You can see the gallbladder would be in here, which you can't see, but you can see gas in the liver. You should never see gas up here in the liver, and that indicates that gallstone ileus, a fistula has occurred. And then you can see all the bacteria having a party, and all the methane gas has filled up the small bowel and stretched it out so you can see all the hastrations. That's called stack of coin appearance. It looks like there's coins stacked. But then all of a sudden, what happened over here? How come there's no gas over here? Because we have a complete blockage right about there. Right? Looks like about right at the ileocecal valve is where all these gallstones piled up, and that's caused an obstruction. So you can't push fecal material through the obstruction. And yep, there is a tumor around the stomach region. What else can cause this? How about just a tumor outside of the intestines that's so big it's pushing and pinching the intestines, it's compressing from the outside. And so a tumor, an abscess, hematoma, a lymph node that has swollen up like crazy, those are all causes that can pinch from the outside. Foreign bodies, not that common, but some mentally ill people just swallow things, and kids swallow things, and they're not mentally ill, they're just being kids. But you can get, like this guy swallowed a bunch of ball bearings, a mentally ill patient, and they got stuck, and so they're causing you can see all the gas starting to back up here. They're going to cause a obstruction if they're not taken out. Now, there's two types of block. So you don't have to have a complete beaver dam. So you can have a partial blockage where you still get some fecal material passing through, or you can have a complete blockage, and that's a medical emergency. You're gonna be heading to the ER if you have that one. What's the sequelae of an obstruction? Well, the bacteria are going to swell, cause the intestine to swell up like crazy, and you're going to get the swelling of the wall is going to cause pain, but it's also going to pinch the blood vessels within the intestinal wall. And if you pinch those blood vessels because of the swelling, it's going to be hard to service for the capillaries and blood supply to service the tissue of the wall, the intestinal wall, and it's going to start to die. It's begin to become ischemic and die. You can get a hole in it if things go on. Remember the anatomy here? Here's the run-of-the-mill intestine, but in the lamina propria we have blood vessels, we have a microcirculation, there's an artery, vein, there's a lymph system. I didn't draw the pain fiber, but there's pain fibers in here as well. And then of course in the submucosa there's much bigger blood vessels. Right? So if you get a obstruction right here for whatever reason, you can see all the little blood vessels. Go back to look at all these blood vessels. They get pushed and smashed so they don't work, and so all this tissue becomes ischemic and starts dying, and the nociceptors fire, and you got horrible pain. And if something's not done, the bacteria can eat a hole right. They can eat a hole right through here. Right? And if all this stuff dumps into the peritoneal cavity, you can get peritonitis. You can get in the bloodstream really quickly that way. What's the ultimate sequelae of obstruction? Well, necrosis. As we just said, the bacteria can eat a hole right through the intestines, and that's called an intestinal wall perforation. And once you get bacteria floating around in the peritoneal cavity, then you have what's called peritonitis. And septicemia, the bugs in the peritoneal cavity can quickly get into the bloodstream, cause septicemia, and that's fatal. And back to our cartoon, we can see that we have a perforation here, and now all these bugs and pus are leaking out, and the patient's in big trouble. Right? Whoops, should have warned you another kind of gross picture, but here's a strangulated piece of intestine and an inguinal hernia that occurred, and They opened them up, pulled out the good intestine. You can see we have a piece of ischemic tissue. That tissue is dead. That has to be all cut out. All right, what are the clinical signs of this? Well, horrible pain. You have acute abdomen. You're in the hospital because of the acute abdomen. We said the fecal material stretches the walls out, and those walls, the intestinal walls, have receptors, pain receptors. So those will fire, and you'll have horrible pain. The bacteria can invade the walls, which we just show, cause an inflammation and a perforation. Other clinical stuff. You're not going to get any fecal material through many of these obstructions. And we know that that fecal material is filled with water, and the cells, the enterocytes of the intestine, suck water out of that fecal material, and that's important for keeping us hydrated. So you're going to suffer dehydration because there's no fecal material to suck water out of. Right? And you also, if you can't suck water, you can't suck sodium, so you can become sodium deficient and chloride deficient as well. And therefore you'll get hypotension. Now the R2A system is going to turn on to try to counteract that, but you'll have hyponatremia, and then throwing up, emesis. These patients are throwing up, and that doesn't help things because when you vomit, that's a lot of water you're losing, and sodium and chloride. So that contributes to the loss of sodium and chloride, the hyponatremia, and the hypotension. And hydrogen ion is also lost of it. So you can develop metabolic acidosis from that. And yeah, so together the dehydration and the throwing up, these patients typically present with hypovolemia, which, I mean, you can't measure. It's probably not the good one to put in there. You can't measure their blood volume, but you can measure their blood pressure in the ER, and they'll have hypotension. They'll have low sodium, hyponatremia. They'll have low potassium, hypokalemia, and they'll have metabolic acid alkalosis as well. And the hypotension will activate the R2A system. They'll have high levels of renin floating around, but the R2A system will it'll be sucking a little bit of water out of the filtrate, a little bit of sodium, but that's going to worsen the hypokalemia and the alkalosis because it's kicking the potassium and it's kicking hydrogen ion into the sodium, or into the filtrate. And then partial obstructions, people can get really skinny and malnutrition can occur. You have a tumor growing in there, and it's not enough to cause horrible pain, but it's enough to cause a backup of fecal material and not let that food material, I mean, we need to suck the nutrients out of that, right? So if that's all backed up, you get cheated out of nutrients, so you can get malnutrition from this condition as well. One of the signs of acute, like a complete blockage of the intestine, especially if it's up in the duodenum or in the proximal part of the jejunum, the bile, you can back up bile. Bile is constantly released from the gallbladder, and it can be pushed into the stomach. You can get so much pressure in the duodenum that it starts squirting and spilling over into the stomach. And we said the stomach hates bile. Not only does it cause ulcers, things like that, but it just irritates the stomach to the point it makes you nauseated and want to throw up. So you get a reflex vomiting when you get bile. And here's a patient who has vomited bile, and that's what it looks like. That's called eminence is throwing up, and bile, bilious eminence is throwing up bile. So that's not a good sign. That's not a normal. That's not like a gastroenteritis type thing. That's much more serious, typically. There's a baby that I take to the ER, woke up in the morning, and bilious eminence all over the baby's sheets and blankets. Another common sign is a special type of pain. It doesn't always happen, but early on it happens. And it's called a colicky abdominal pain. And when the fecal material is stuck, let me try to draw this. So here's a pipe. Let's draw a piece of intestine here. All right, and then we got something stuck, or we got a tumor, or whatever. We have a beaver dam right here. Fecal material is heading that way, and we'll make fecal material, or fecal material is red here. It's stuck now. So normally we have a wave of peristalsis that pushes this, right? So there's like a rhythmic contraction that's pushing this. But now, because of the stretch receptors, the intestine senses that, uh-oh, something's stuck. And so what happens is, over and over, the peristalsis will go stronger and stronger, just in this little region, not the whole intestine. So it squeezes again. And as it squeezes hard, it hurts. It causes severe pain. And it tends to ramp up. So you got this horrible pain as the intestine contracts, almost completely contracts to try to shoot that forward. And then the intestine relaxes for a minute to kind of recharge. And then it goes again. So you got these waves. It's called crescendo, decrescendo. You have these waves of horrible pain, and then it backs off. And then you wait a minute or two, and then it comes again. That's a colicky abdominal pain, and that often can indicate intestinal obstruction. Right. Let's see, more clinical signs. Constipation, because there won't be any, or obstipation, right? If there's no bowel movements at all, you have obstipation. Constipation is defined as less than 3 bowel movements per week. So if you've had 1 bowel movement in the last week, you're obstipated. So in addition to their other signs, that they have no pain, or maybe the pain won't have. Remember, the fecal material that gets trapped downstream from the blockage, it's not going to have any water to kind of thin it out and make it more manageable. So it'll be super sticky, and it won't want to come out. You might have to put your fingers up there and pull it out. So that's constipation, and that's common with this type of blockage. Tachycardia from you have signs of hypovolemia. You have tachycardia. You have a lower blood pressure. Your heart will compensate by speeding up and pumping faster. Hematochezia. Did we talk about that? Hematochezia. That is red blood that's mixed in with the stool. It's not hemorrhoid blood, and sometimes they're hard to differentiate. But it's usually blood mixed in with the stool, and that's a sign that something is bleeding. Your obstruction has become infected so bad that it's ripped a hole in the inner part of the intestinal wall, and pretty soon the whole intestine will be ripped through, and you can get a peritonitis from that. Distended abdomen, so you're going to be filled with gas. The bacteria, there's a huge roadblock, and no fecal material is moving, and the bacteria are multiplying, and you're all filled up with gas. If you percuss the stomach, it's going to be tympany everywhere in this big swollen up stomach. If you auscultate, you might catch hyperactive bowel sounds. We'll talk about that. Or we did talk about that, right? Clicks and gurgles, 5 to 35 sounds is normal per minute. So you'll have 100 sounds when you auscultate if it's early in the obstruction. If it's late in the obstruction, you may not hear any bowel sounds. Deep palpation may over the site where the pain is the most may be incredibly painful. They can also have involuntary muscle guarding. So when you push in there, they tighten up because they know it's going to hurt because they've been poking around in there. So they don't want you poking around here. And maybe it'll be involuntary guarding. So they can have voluntary guarding. Or maybe their body has naturally caused their abdominal muscles to contract to protect the area. That's a really bad sign that peritonitis might have started. And we should talk about some peritoneal signs. Peritonitis can kill the patient. That's a medical emergency. They got to get to the ER immediately. So let's look at peritonitis. If they cough, you could have them cough for me, and if it causes really bad pain, and let's say the left lower quadrant is where they have the pain, it causes left lower quadrant pain, worsens it, sign of peritonitis. If they have any type of muscle guarding there, if it's voluntary, then it's guarding. If it's rigidity, that means it's involuntary. They can't control it. That's a much stronger indication of peritonitis if they have rigidity or involuntary muscle guarding. Rebound tenderness, you just poke into the left lower quadrant slowly and deeply, and then suddenly snap your fingers up and let the pressure off, and that sends a shock wave through the peritoneum. That will hurt. There's another test you can do. Maybe this is a stronger indication for peritonitis if they have left lower quadrant pain. Maybe you can't do a rebound test on them because you can't even push in there, it's so sore. Go into the other quadrant. Go about 6 to 8 inches away from the site of pain and push your fingers deep into that area, and then suddenly release. Do a rebound test 6 inches away from their pain. If that recreates pain where they normally feel the pain in our example in left lower quadrant, that's a pretty good sign they have peritonitis, and they better get their butt to the ER ASAP. Peritonitis can kill you because it goes into septicemia so easily. So there's a name for that. It's called the Blumber's sign. Blumber's, almost like lumbar, right? Lumbar spine. So you can just remember it as kind of lumbar with a B. Blumber's sign, or adjacent quadrant rebound tenderness. All right. Yes, there's Rolfsing's sign as well. We'll talk about that in lab. I think we'll talk about that later. That's specifically, it's a sign, it's an adjacent quadrant rebound test, but that's specifically for appendicitis. Blumber's sign you can do anywhere. All right, this is just rebound tenderness. You push your fingers, the fingers are parallel to the surface of the skin. You push them in slowly, and then you jerk your fingers up. So if they have pain right here, maybe just pushing your fingers in will cause pain and you won't even have to do this. But if you can push your fingers in there and they're okay, and then you suddenly snap your fingers back and they have really bad pain, that's a sign that peritonitis has started. Okay, we talked about guarding and rigidity. Again, guarding is a voluntary contraction of the muscle wall. We've talked about this. Rigidity or involuntary contraction, that's not a good sign. In fact, that quadruples the chances of them having peritonitis if they have a rigidity. If they just have guarding, it doubles the chances of peritonitis. But if they have rigidity, involuntary contraction, that's not good. How about some other common causes of guarding and rigidity? Well, these are the same causes of the acute abdomen: appendicitis, cholecystitis, perforated bowel from small bowel obstruction. And I mean, there's more than that. What about lab findings? Well, basically we said these already. Dehydration findings. So you'll get lab findings that are consistent with dehydration because there's no fecal material going through the blockage and your intestines aren't reabsorbing water, salt or water. And so, yeah. So let's see, emesis. Oh, plus throwing up too. You're also going to lose salt and water through throwing up, as well as hydrogen ion and potassium by throwing up. So what are the findings then? Well, alkalosis, hypokalemia. Is that, I mean, I don't know where the other slide went. All of those things we talked about. But I guess these are the two most common according to this author. If the white blood cell count is elevated, that's also not a great sign. What about radiographic findings? We've talked about this. You can see loops of small bowel upstream from the beaver dam. If the patient, I believe they have to be standing to see the stack of coin appearance, but you can certainly see a lot of gas in the intestines, and then there will be a lack of gas downstream from the blockage. Yeah, if you see air in the intra-abdominal, or the presence of free intra-abdominal air that's outside of the intestines, indicates perforation. I'm not going to get that deep. But it's supine that you have to see this, not standing. So if the patient's laying face up, we can see stack of coin appearance, right? This is gas. And it looks like these are all stacked coins. And we can even see where the obstruction looks like it's right here. So it looks like ileum, but it's not the ileocecal region. Assuming this is left over here. The ossicular region would be right here. So, and then there's no gas over here. Where's the gas in the where's the intestinal gas or the large intestine gas that we always see? Right? Where's the segment colon? Just a tiny bit there. So yeah, classic. We looked at this gallstone ileus just to show you another case where we have gas inside the gallbladder, which you should never have gas in the gallbladder. That means that a fistula has occurred between the small bowel, and this patient ended up having gallstone ileus. Functional obstruction. So this is the other big category here. So ileus means that the whole intestine and small and large intestine is stopped working. It's like paralyzed. That's why they call it paralytic ileus or adynamic ileus. Can you imagine that? And yeah, it mimics a small bowel obstruction because all the food is stuck. None of it's getting through, and this is definitely a medical emergency. Peristalsis has stopped working, and it's considered a functional obstruction because there's nothing physically blocking the lumen of the intestine. It just peristalsis stopped. What causes this? By far the most common is an injury to the peritoneal lining. Surgery, anytime you have abdominal surgery, it takes a while for your peristalsis to wake back up. It's paralyzed. Or if you get stabbed by a knife or something like that, and you have food in your, because if you have surgery, you don't have any food, right? You have to be fasting to have surgery and type of abdominal surgery because of this. But if you have a full stomach and you have full intestines and you get stabbed in the stomach, now you're in trouble because all the intestines might shut off, and the bacteria are going to run wild, and your intestines are going to swell up like crazy. Hypokalemia is the other most common cause of this thing. Patients with severe diarrhea, where they lose potassium, this can occur from that as well. Other causes are tricyclic antidepressants, opioids. Not everybody, though. Some people seem to be susceptible. It's rare, but it can happen. Peritonitis, if the peritoneal lining gets really inflamed, all the intestines will shut down. Abdominal aortic aneurysm that bleeds. The intestines don't like blood in there, and they'll shut down, stop working. Intra-abdominal bleeding. Yep. Talked about that just now. The bleeding causes hypovolemia, which turns on the R2A system, which releases aldosterone, and so you get hypokalemia from this bleeding as well. But look at this compared to the stack of coin appearance. So this is a patient with ileus. He was on tricyclic antidepressants and Percocet for chronic low back pain, and he's one of the susceptible ones. All of a sudden into the ER, horrible pain and abdominal pain, and the signs of small bowel obstruction, which they thought it was, and they took a simple x-ray, and everything is blown up. Bacteria just running wild in here. So that's not a good thing. All right, what are the clinical signs of ileus or a functional obstruction? Well, dehydration can come on really quick because you're not reabsorbing water anywhere. And then the rest are about the same as a small bowel obstruction. I mean, you're going to be in the ER with this, right? You're going to have acute abdomen with this thing. Perforation is less likely, though, because the bacteria buildup is more spread out. So it's not focal in one spot. So, I mean, by the time you got a perforation, you'd probably be dead of hypovolemia. There are some differential diagnoses. Mesenteric artery, superior or inferior mesenteric artery ischemia. What if you get a blood clot and it blocks the superior mesenteric artery? Right? Remember how it supplies all the intestines, the ascending colon. All that tissue would start to become ischemic, and so that would be horribly painful, and it can simulate this small bowel obstruction. Definitely a cause of acute abdomen, mesenteric artery, whether it be superior or inferior. Number one thing to do that is probably an arterial clot in somebody who has atrial fibrillation. But a tumor growing into that could pinch that off as well. Yep, angiography you can order to make the diagnosis. Could also come on slowly from atherosclerotic narrowing. Atherosclerosis usually doesn't affect vessels that narrow or that small. Remember, it's more of a big vessel disease, but it could happen. Okay, just to remind you, there's the superior mesenteric artery, and look at all the intestines, all these intestinal arteries, right? All the jejunum, all the ileum, and the ascending, the cecum, ascending colon, and even part of the transverse colon, which is not shown here. So you get a tumor, or you get something pinching the pipe, or you get a blood clot, you get an embolism stuck right there, you're in big trouble. Right, all that tissue will become ischemic. What about, we talked about small bowel obstruction, what about large bowel obstruction? It can happen as well. The lumen is much bigger, so it's a little less likely to happen. But if you do get it, it can be confused with small bowel obstruction. You won't have bilious eminence, though, and you're not going to have much diarrhea because the intestines have already absorbed most of the water, but you can still get severe acute abdominal pain from the bacterial buildup and lots of gas. So it doesn't happen that often. How do you treat a small bowel obstruction? Well, in the ER, they'll treat you for the dehydration. So fluid resuscitation, you won't eat any food, you don't want to feed that bacteria anything, and you just watch to see if your body can push through. Maybe the peristalsis can eventually push through, or the beaver dam will break down, the bacteria will chew up. If it's a fecal beaver dam, maybe the bacteria will finally eat away the fecal material enough to get you going again. If that doesn't work, you're going to have surgery. All right, you have to cut out the dead part or the blocked part of tissue, and yeah. If it's caused by a hernia, you can try to push the intestine back in. The surgeon can try to do that. Trouble is, the intestine is all inflamed, and you could rip the intestine by doing that and cause peritonitis. So, I mean, ultimately, surgery is going to be needed if it doesn't fix itself. And yep, here's another intestine that was strangulated, and you could see all the tissue is necrotic. That's gangrene. And so the patient waited too long, and the surgeon will come in there and cut that out, and hopefully they'll be okay. Mortality rates, if it becomes gangrenous, even in a good hospital, and you wait more than 36 hours, about a third of the patients will die, even with surgery. So you don't want to ignore pain, right? Pain is the warning sign of the body. What's the normal prognosis postoperatively? The mortality is very low for non-strangulated hernias, so probably under 1%. For strangulated hernias, it's about 8% mortality. Even when the surgery is performed within 36 hours, though. Remember, we said if it goes after 36 hours, it's a much higher, almost a third of patients will die. All right, lots of stuff. So digest it. See you guys later. Email me those questions. See you later.